Now we will hear from our virtual keynote speakers before breaking for lunch. Joining us virtually here today are Dr. Peter Hotez and Dr. Maria Elena Bottazzi, Deans of the National School of Tropical Medicine at Baylor College of Medicine and co-directors of the Center for Vaccine Development at the Texas Children's Hospital. Dr. Hotez and Dr. Bottazzi are nominees for the 2022 Nobel Peace Prize, and their work to develop and distribute low-cost COVID-19 vaccine to people all around the world without patent limitation. They'll be joined in the conversation by David Kotok, GIC board member and chief investment officer of Cumberland Advisors. David, it's great to see you again.
Nice to see you, Emily, and great job this morning so far.
Oh, thank you. You're too kind. Doctors Bottazzi and Dr. Hotez, are you here?
We're here.
Yes, we are.
Beautiful. Oh, that's so wonderful. Thank you so much. I'll step back and enjoy the presentation, everyone.
Thank you.
Thank you. I guess I'm the moderator, Peter and Maria Elena, and we have our pre-discussed list of items, but let me just open by saying that it is a humbling experience to moderate a panel with two distinguished academicians with great credentials who have contributed greatly to society. And in my humble opinion, your work, Maria Elena and Peter, rank you with the Jonas Salk and Maurice Hillman work in vaccine development history. Your work essentially will save many, many lives. So we wish you well for the Nobel. If it were up to me, you'd have my vote already. So without further ado, because of the profound nature of the work that the two of you have done, I wonder if first each of you could say a word or two about exactly what you did and how you developed the vaccine relationship and research, and what you did, which essentially created a gift to the world, to millions of people. Peter, do you want to start, and then Maria Elena next?
Sure, happy to, and thank you for that very generous introduction. I knew both Maurice Hillman and Jonas Salk personally, and they're both fantastic individuals. Maurice had a particularly colorful use of the English language, which we can have an offline discussion about sometime. What we do is our vaccine development effort, our Texas Children's Hospital Center for Vaccine Development, is we've been in place for 20 years. And the idea behind it is to make the vaccines that the pharma companies can't make or won't make because they're mostly for diseases of poverty. So although we're best known for our coronavirus vaccine work, we've been making vaccines for diseases such as female genital schistosomiasis that affects 40 million girls and women who live in extreme poverty on the African continent, Chagas disease, a condition of 6 to 7 million people live in extreme poverty in Latin America, hookworm infection, etc. Then about 10 years ago, we started making coronavirus vaccines. And we use many different technologies. Our first choice is to use one that's always compatible with vaccine producers in low and middle income countries. So we're trying to say that while the multinational pharma companies do a lot of important work and they provide vaccines for the Gavi Alliance, and that's not to be diminished, we think the ecosystem has gone too far tilt with the mistaken belief that only the big pharma companies can do this. And as a result, we're missing opportunities to make vaccines for regional importance like female genital schistosomiasis, because the pharma companies will never make a vaccine like that will not provide adequate financial return. So that's where our model and our approach comes into place. And we began making coronavirus vaccines 10 years ago, and we used a microbial fermentation process in yeast. And the reason you need to know that is that's the process used to make recombinant hepatitis B vaccine. And vaccine producers in India, Indonesia, Bangladesh, Vietnam, Thailand, Argentina, Brazil, the list goes on, make their own recombinant protein hepatitis B vaccine. So we did that for SARS and MERS. And then when the COVID-19 sequence hit, that's what we did. And now the vaccine has been released for emergency use in India. It's gone into 30 million kids in India so far. And now it's also, we've transferred the technology with no patent to Indonesia and Bangladesh and now Botswana. So hoping to make a low cost, and it's, simple refrigeration. The least expensive of the technologies, 145 rupees a dose, $1.90 a dose. Simple refrigeration, best safety profile of any of the vaccines. So it checks a lot of the boxes for global health, and we're hoping this is going to make a difference.
I wonder if Maria can add, and so we can get a sense of your roles with each of you.
Absolutely. So first, let me actually expand a little bit, maybe what Peter was talking about, our philosophy, right? And the decision that all of that, what Peter said, it's still, however, done embedded within an academic health sciences hospital, especially pediatric hospital system, because there's two add-ons that you could arguably say we are also contributing to. So one is the fact that being academics and scientists that we need to train and teach the next generation, right? And however, the way that we teach and train our next generation has a little bit of a unique mindset, which is train them to certainly become the next generation of scientists and vaccinologists in our case, but doing it also with a little bit more mindset towards what we call regulatory enabling science. So of course you can do basic academic science. You can certainly do translational science. Of course, there's many that also do clinical research, but we want to make sure that everything that it's done, it also entertains the fact that if you really are serious at designing new potential technologies like vaccines and make prototypes, you have to understand the regulatory environment that you also need to eventually, propose these solutions to, right? Because they are the ones who attest the quality, the approval, the pathway to, the critical pathway. So that's point one. And then second, this concept of training, it's done in a way where we do it in a manner that it's decolonizing also the transfer of these intellectual concepts and these technologies, enabling others to be able to replicate it and do it. And that's why when Peter said we're very selective of the type of technologies that we use, because it has to be appropriate for where the settings of where these potential products should be developed and eventually evaluated and hopefully used. And this is the reason why we want all our science to be open science. And that's why we not only publish, of course, we widely publish like many academics do, but we also remove these barriers of intellectual property or very onerous contractual and negotiations, because we really what we're not really interested in. We create everything and then we just give it to someone, but that they wouldn't be able to replicate it on location. So we really want to replicate that, so that they can then have their own creativity and fashion it in the way that it's suitable for their culture, suitable for their people, and suitable for their use. So that's the stems of our philosophies, not only, of course, anchoring very good science, but bringing in, the academic creativity, but, evolving the academic creativity in a way that eventually you can decolonize also the training and education, because it all starts with workforce, right? You have to have the right people to learn the right things of how you do science. And then eventually even those same individuals are going to be the ones ending in the leadership positions of the countries, right? So then it will also bring the policy alignment behind it, right? The political will, the financial, incentives for middle income and low middle income countries to learn what we do.
How, just so all of our listeners, and here we are in this marvelous new world So Maria, you're currently, where are you at this moment?
So I'm actually sitting in Honduras. I came yesterday because my father lives here. Of course, I've been working here and trying to model this concept of decolonization, right? Of helping my alma mater, my university here in Honduras, to be more modern, right? In the way that we create these interdisciplinary teams approaches, but by bridging microbiology with other sciences. And then also because in a couple of weeks with Peter, we are getting an honoris causa degree, here at my university. So very happy to welcome Peter to come to Honduras in a couple of weeks or so.
In a couple of weeks. And Peter, you're in Texas in your office at the moment, am I right?
Well, I'm actually at home. I'm actually recovering from COVID-19. So,
All right.
I'm isolating at home.
I was going
but
to.
people recognize the background because for the first year of the pandemic, I was on CNN and MSNBC from this office. So it has some iconic attributes, even if the cat is sleeping on the other side of the laptop.
I remember those interviews, seeing you, and you've been describing your own journey with COVID, also with Paxlovid, and then the second round of Paxlovid. And I know we're in a fireside chat, so I have the liberty as a moderator, although we don't have a fire or a fireside, to say, how are you doing? How are you feeling? Give us a 30-second personal summary of where you are in this journey.
Oh, I feel much better this morning, thanks. The congestion's evaporating and fever's gone, and so I feel a lot better. A little bit of sore throat, and so sometimes I start coughing, but I feel good. I think what happened was, now that we started returning to in-person events, even though the BA.2.12 variant is accelerating, people want to do in-person events, so I attended a few of them. I was speaking at a few of them, and between shaking hands and selfies and all of that, it's no surprise what happened. Doing fine. I was on Paxlovid and did well, but then I got a rebound on Paxlovid, which apparently has been happening with higher frequency. So, but doing fine, thank you. Hopefully it's just a temporary inconvenience because I got vaccinated and doubly boosted. If I hadn't been vaccinated and doubly boosted, obviously it could have been much more catastrophic.
Yeah, we're going to get to the vaccinated versus non-vaccinated long COVID in another 5 or 10 minutes. Just one more quick personal note for our group. Maybe I'll ask Maria Elena to go first. How did the two of you get to work together, and how long have you worked together, so our audience knows about your collaborative history?
Oh, yes. And it's been 21 plus years of being, I call ourselves the dynamic duo, right? I have to say it's been just an amazing ride to be alongside Peter for these 2 decades. It was quite honestly very serendipitous. I think Peter, in the late 1990s, early 2000s, was being recruited to the George Washington University, to establish a new department of microbiology and tropical medicine with the aspiration of creating all these vaccines for tropical diseases. I'm a microbiologist, trained in tropical diseases from Honduras. I was actually doing my postdoctoral degree at the University of Pennsylvania. And he met the First Lady of Honduras at that time, Mary Flores, in an event in New York. And Peter always wanted to find ways to come to Latin America to learn about, how we could do work here, came to visit Honduras. Everybody spoke about me, how, I was someone who was as passionate as him of understanding these microbes and looking for solutions. We connected, and I think, we just clicked. I don't know, we clicked, and we bring both very complementary skills. Our personalities are very complementary. I love the administration, so I also got some training in business administration. So I do a lot of the, managing the programs, the staff. And I think we had a great ride trying to really build, with not only both of us having a very similar, philosophy, but a team of, now I think we're around 60 people plus in our school division of tropical medicine and our vaccine center. And they are so passionate scientists, also very like-minded. We say that we're running a little bit of a roach motel, because once they join, they really don't want to leave, right? And I'm sure they would do a much better in the private sector, but they just stay with us, and they really feed, and we all feed from each other to really, again, try to be good and try to do things that will touch the lives of many that certainly don't have a voice.
So
Or
instead
as I
of,
like to say it, Mary Elaine is the brains of the operation, and I provide irrelevant quotes from Hannah Arendt and Abba Eban and White and Churchill. So,
And a
well,
lot of our social media, face for sure.
well, I like all your sources, and like Hotel California, Hotel Baylor, everybody comes, no one wants to leave. So that's good.
yeah, I mean,
You
the
have,
Texas Medical Center, not a lot of people know about it. It's the world's largest medical center. It's a medical city of 100,000 employees and 60 institutions and extraordinary resources as well. And Houston's a very philanthropic community. And one of the things that happened was we weren't supported by Operation Warp Speed. And because the thinking was only the pharma companies had the chops to know how to do this, and it had to be new and innovative, and no one ever gave some thought to the fact that we were also going to need vaccines that could be produced locally. And that attitude by Operation Warp Speed contributed to the terrible vaccine inequalities that allowed the Delta variant to arise out of unvaccinated populations out of India, and then Omicron out of Southern Africa, then BA2. It all could have been forestalled, and we knew that. And but being here, so we got support from the JPB Foundation in New York, but then a lot of Texas philanthropy really came through, which we knew is one of the reasons we relocated there, is because we wanted to build on that very powerful medical center in Texas Children's Hospital and Baylor College of Medicine.
So tell us for a minute, you have a preprint, your latest research piece, I think. Can you tell us?
We have about a dozen
Yeah.
publications. So what's interesting is we've published every step of the way of how we make the vaccine in the open access literature. So in theory, you don't even have to contact us. You could just reproduce the papers and make the vaccine. Although we make it easier by transferring the production cell bank and the technical know-how to how to scale it up and produce it. And then there are about 3 medRxiv preprints from Biological E, one of the groups that we transferred it to on the clinical trial. So everything is put out in the public domain, much more so than the pharma companies, for instance.
But I think what David is asking us is also our interest in, again, this intersection of having had COVID and therefore long COVID, and how can we understand a little bit better the impact of vaccination versus non-vaccination. So there's a couple of things we're doing. So with Peter, we also sit as co-leads of the Lancet Commission on COVID-19, the task force for vaccine and therapeutics. And with the Lancet task force, we have a draft article that we're already working with one of the journals that specifically addresses what do we not know? Like I think Melissa was talking, with her very nice study. What do we know? What are the gaps? What's the benefits indeed of having vaccinated people? What's the impact of having therapeutics like Paxlovid, for example? And then separately, we're also, similar to the work that Melissa described earlier, we have also been working with health economists. We work with a group led by Dr. Bruce Lee from City University of New York. For years, we've been doing cost economics, or disease cost, illness, burden of disease economic models. And with them, we're also looking at, again, how can we understand better the scenarios about having been vaccinated, how many doses of vaccination, the arose of all these variants, the impact of that, plus what we're starting to learn about long COVID. And I think it all really starts on the definition, right, of what are we defining as long COVID, right? Everybody may be defining it in different ways.
I mean, the data shows, I think, that it's still preliminary, but the data is showing that vaccination will reduce the likelihood of you're getting long COVID. And we're still learning about it and still understanding the risk factors for long COVID, as I'm sure you've been discussing. The data so far is suggesting women more than men in terms of risk factors greater. Anybody who gets COVID could get long COVID, although the risk factors are greater with more severe illness. Exactly why vaccinations reduce the likelihood of long COVID may just be as simple as that it's reducing severity of illness, and therefore maybe that has an impact on reducing long COVID. So it's still early stage, but in that preprint, we tried to put together the existing literature, and it's definitely trending towards vaccination as having an impact on reducing the likelihood of long COVID.
So let me do something. This is a surprise. It was not in our pre-conversation discussion, but I saw from Dr. Jetelina a reference to an ONS recent slide, and I sent it yesterday to Siona at GIC, and I said, can you put this slide up? And I have one slide instead of 0 slides. So I apologize in advance for surprising anybody. And I wonder if we could just look at it for a few seconds, and then we'll take it down and resume the conversation. So the slide comes from the British recent release just a couple of days ago. And it's showing long COVID reported cases in the UK from fully vaccinated folks, and it's self-reported data, and it's breaking it down by variant. And I was struck by looking at the slide, and if everyone's had a chance to look at the slide, we can take it back down and resume our conversation. So what I was struck by the slide, Colleen, we can take the slide back down now. What I was struck by the slide is it seems pretty much it makes no difference which variant you have. The proportions of long COVID self-reported in the UK are roughly the same. And that's among fully vaccinated and boosted people. Now, it's the UK data system. We've had conversation about deficiencies in US data, and we know some of those problems.
Well, actually, the data looks, it's the first time I'm seeing it, but it kind of makes sense if you think about it, because if it's true that the risk of long COVID increases with severe illness, point one, and if it's true that vaccination reduces the risk of severe illness, and that's the mechanism by which vaccination reduces long COVID, pretty much the vaccines are equally effective at reducing severe illness, whether it's Delta or Omicron or BA.2. The vaccines are not as good at protecting against infection, right? I'm the poster child for that, for BA.2. But the point is they're all reducing severe illness for all of the variants, and that may be the reason why you're seeing a protective effect, and it's equal against all the variants. Also, if you notice the numbers, the absolute numbers, they're far lower than that 30-35% typically reported associated with long COVID, and that's, again, the effect of vaccination.
So, I would maybe, if I may, David, it's interesting because you pointed also, of course, unfortunately, we always get these data from countries as UK, maybe sometimes Israel or others, where, of course, the health systems are pretty good, right? And you can maybe even make some assessments. But I wonder what would be the difference if you take some, Latin American countries where also that different vaccines have been used, right? Here we're also talking that they're probably very much either RNA or even an AstraZeneca, type of vaccination strategy, and that they have had access to multiple doses probably, right? Versus in locations that we may not have the same type of vaccines, that they may not have been able to get more than maybe their just initial 2 doses and no boosters. So it's going to be very interesting even at that level. But I totally agree with Peter that thankfully, at least vaccines, and hopefully, where we can get more vaccinations, we can ultimately reduce the potential of having severe disabling long COVID. That's the key at this point.
So let me ask this. We have a few minutes left for our fireside chat, and I do hope in the future we can do this in person. How do we get the conversation? You talk about scientific diplomacy. You talk about teaching. Both of you are pioneering in vaccination, and you're also teaching in such a major environment. How can we get this conversation to the point? Eric Topol just had a conversation about it in his Substack, and he said we need to stop talking about infection, and we need to say vaccination cuts long COVID risk in half, more or less, and cuts death by a huge amount. And how do we get this conversation about vaccination into those metrics and repeat it? What are the messaging? Because we're in a task. I've watched the criticisms of you on certain, what I would call fully discredited media outlets. And I myself and you have been victims of disinformation targets. We are trolled by a universe of people who have self-interest in monetary subscriptions to their unfortunately false newsletters and selling snake oil remedies. And so we have a divided world. How can we get this conversation to talk about the work you do, what vaccinations do to prevent COVID death and COVID long disability, and not talk about infections which we can't even measure? We just listened to the Smallwood presentation on numbers which have to be guessed at in the United States.
Well, I think you
what
have
do we
to
do
remember,
about that?
I think you have to remember that part of the anti-vaccine lobby, which includes now, unfortunately, members of Congress, and it's amplified on Fox News at night, and there's even this group of contrarian intellectuals, is their first approach is to dismiss the severity of COVID-19. And so, for instance, they'll point out the relatively low death rates in kids or in young people, which is also not even factually correct, but that's one of their things. And they, of course, part of their agenda is to totally ignore long COVID, as though it doesn't exist at all. So I think, so I think it's forums like this that are extremely helpful, emphasizing that as bad as the 1 million deaths has been from COVID-19 in the United States, we just saw that presentation, which was excellent. That's unfortunately the tip of the iceberg. Long COVID is going to haunt our nation for years to come. It's going to haunt us in terms of the devastating mental health impact because of the neurocognitive decline with long COVID. It's going to haunt us because of the disability and people leaving the workforce. It's going to haunt us economically. And so much of that could have been prevented from vaccination. And by the way, there's going to be a regionality of long COVID, just like So many people were defiant of COVID vaccines in conservative strongholds in the U.S. and Texas and the southern United States where we are, and in Appalachia and at the Mountain West. Guess what? That's where the long COVID's going to be, and it's going to be on health system which are already depleted as a consequence. So this is going to be a pretty awful marathon, and I do appreciate the opportunity to have that discussion with you today.
Maria, is the same conversation taking place in Central America and South America? Can you comment on that?
So I have to also remind everyone that in context, when you are in a country such as Honduras, which of course has 100,000 other challenges, right? Not only economic, social, that already you have an underlying level of poverty that it's, even, exaggerated maybe compared to maybe other places. So unfortunately, therefore, it's very hard to engage those who make the policies or the governments to focus on things that are that cause long-term disabilities, because they're always trying to react against the things that are immediate, right? That they have immediate impact, the mortality, the deaths. So I think the conversation here is always, you grab more the attention when indeed you're making the case of strategies that avert certainly deaths, right? Rather than focusing on preventing long-term consequences. So I think that's going to be a challenge, right? Because we know here they put in practices, and certainly here is probably a lot more accepted, the vaccination. I think Latin Americans have been much more acceptable of coverages of vaccination, even for our kids. But I think it's evolving because they don't understand, the concept that these vaccinations are there to protect the long-term sequelae, right? And they, again, I think, as Peter mentioned, I think people now are getting in their heads that this is just as a regular cold, that it's not serious, and that now, even if they may have gotten a vaccine earlier, that there's no need for them to continue boosting their immune response. So I think it's arriving here, even in our cultures. A lot of the anti-science, a lot of the reframing the truth to make it fit to whatever they wanted, make that truth sound. And therefore an excuse for our potential even leaders of why not invest into sustainable, proactive strategies to make the health systems more robust in the area of again, preventive long-term consequences of diseases such as, of course, long COVID.
So we only have a few minutes left. We've talked about South America, Central America. We've talked about India and your effort in 30 million now vaccinated. COVID in Asia is all over the headlines. I don't think there's much to be added to that conversation. We forgot Africa, and you have an initiative as well in South Africa. Can you, maybe one of you just say 2 words, 2 minutes, so we cover the globe? Remember, this is the Global Interdependence Center, so we don't want to leave anybody out.
Well, the African continent is largely unvaccinated, and that's very troubling. And again, we paid the price for that in the U.S., allowing Omicron and BA2 to arise out of an unvaccinated population in Southern Africa. We have a partnership with the government of Botswana. The president came to visit us last year, and he's very committed to making Botswana an innovation hub. And we transferred our technology to an organization that's seeking to build capacity there called Immunity Bio. That's headed by Dr. Patrick Sung Shung, who's a high net worth individual, made his money in biotech and owns the LA Times and part owner of the Lakers, who actually grew up in Southern Africa, wants to give back. So that's moving. The vaccine's been approved. Corbevax has been approved in Botswana. So this is a very exciting new adventure for us to build that capacity. The factory that's going to produce it is built on the edge of the Kalahari Desert, near the Botswana, South Africa border, and it's moving. So we're really one of the things that we have a commitment to do is not only to build vaccine development capacity in terms of actual vaccines, but also the human capital. That's often the rate limiting step, because learning how to make vaccines at scale under a quality umbrella, quality control, quality assurance, our facility is open to people internationally to teach people how to make vaccines. Whereas I like to say, you can't walk into GlaxoSmithKline or Merck or Pfizer or Moderna and say, teach me how to make a vaccine. With us, you can. And we have that commitment. We've been doing this with, Mary Elena and I have been doing this with Mexico and Brazil and Malaysia and the Middle East, and now doing this with Botswana. So it's another very meaningful activity for us.
So a very quick question, Maria Elena, if you would just maybe add 2 minutes, Peter, as well. BA4, BA5, new variants. Give us a futuristic look.
Sure.
Just a less the word kind of summary as to where we're going with variants, given the world that we have, not the world we would like to have.
So very importantly, in fact, we were actually thinking about this even pre-COVID, is this notion of how can you create maybe a cocktail of vaccine prototypes that can give us a little bit of certainly more durability, more broadening, so that we can maybe even cover the unknown new coronavirus to come in the future. So we've already been working in our labs to look at that strategy. Even maybe sounds a little bit, simplistic, is even combining our prior SARS vaccine, our SARS original prototype SARS-1 vaccine, with combining it with a COVID-19. And then within the COVID-19s, we're already evaluating, can you mix match an Omicron protein together with a Delta protein? And is that going to give us a more durable, where we don't have to maybe vaccinate every 6 months? Can we do it every 1, maybe every 3 years? So we're already looking at that. So I think the next generation of vaccines will be either multivalent or at least bivalent type of vaccines, where we're going to put them together in a strategy that can not only protect us still for severity of disease, maybe having a more broadening immune response and with a much longer durability of an immune response. And then be very aware of the surveillance to see how quickly we can understand if there's potentials for any new spillover, certainly by looking at the bat coronaviruses and other veterinary viruses.
Well, let me thank you, and let me thank Peter for your wonderful work. Applause to both of you. 21 years, you just began. You got a wonderful future ahead with this marvelous institution that you are in charge of. For our viewers, just a quick moment, there's going to be recordings of this entire conference available, and we would encourage that to be shared when they're available as widely as possible. The second issue, and maybe a last 30-second word from Peter and his colleague who is joining us from Honduras. What a marvelous world we're in to be able to do this. We heard a number this morning, 28 million Americans with long COVID. We saw ratios. I, for one, use a ratio of at about 11 serious long COVID cases for every reported long COVID death. And I modify that in statistics by using the IHME excess death mechanism as a reference, but we could debate the numbers. It's not the numbers. We have 11.5 million job openings in the United States. Last time we counted them a few days ago. We're going to hear from Philippa Dunn soon about that. And we have a little under 6 million people looking for those jobs. And we have this cohort of some number of millions of people who have partial, temporary, or permanent disability from COVID. And we heard from Melissa about how we're trying to measure them. And we heard earlier some extraordinary discussion about trying to identify long COVID in someone. I don't know that I can even spell the medical terms that were used in the earlier presentations today, but I'm going to have to look at the replay in order to do that. So where do we go in the United States with long COVID, the impacts on the age 16 to 65, labor force age, the economic shock, not the payment for the disability, but the labor force impact in the US. How about a last word, Peter, on this one? And Maria, let me thank you. It's nice to see you. And Peter, maybe a last word on this economic labor force shock.
I'll just say that, it begins by having an honest discussion with the American people. We've not heard from this administration a frank accounting of long COVID and the extent of it and its impact on the health and vibrancy and the economic recovery of the country. And my point is always you can't solve a problem unless you can at least begin by articulating it. And I think that's the beginning, is we need the high. And I've actually had this conversation with the leadership of the COVID response team in the White House. This has to be prioritized. It's the 800-pound gorilla that no one talks about. And here's how I know, because whenever I mention it on my social media, on my Twitter, that invariably gets hundreds of responses. There's so much suffering out there right now. And people are upset and mad, one, because, they're upset and mad because they have chronic debilitating illness. But what's made even worse is that no one will talk about it. And I think that's among the most hurtful of all. It's, as MLK says, it's not the words of your enemies as much as the silence of your friends. And our friends are being too silent on this issue. And we've got to find a way to have this national dialogue and national discussion and at least acknowledge people suffering. And I think that's going to be an important first step, in addition to outlining a national strategy around disability and the fact that we already have a depleted health system, as I sometimes say in my frustration to make a point. Israel and the UK, they have a national health system. We have something called Amazon Pharmacy, right? We don't have a health system that could even begin accommodating this, and we've got to figure out a way to do this.
Well, let me thank you, Peter, and you, Maria Elena, and you are very kind to give us your time. You have, in this audience, great support, admiration, and you know it. And keep up the magnificent effort as you continue the tradition of Maurice Hillman and save somebody's life. There's a biblical teaching. It says if you save a single life, it's as if you saved the entire world. I think I'm quoting it fairly closely. And I would say both of you get 5 stars for that effort. It's been a great fireside chat. Now we're keeping the people in New York from their lunch, so I think we should let them go to lunch. Emily, let's turn this back over to you.
Thank you
Great.
so much,
Thank you.
David. It's an absolute pleasure. Yes, one more round of applause.